I'm Eric Cohen. I'm a staff cardiologist here at Sunnybrook, and I co-chair the Clinical Operations Working Group of the Environmental Task Force.
Hi, and my name is Danette Beechner. I'm the Director of Pharmacy at Sunnybrook, and I am Eric's co-chair on the Clinical Operations Working Group.
Hi, I'm Martin Vanneviver. I'm a staff anesthesiologist at Sunnybrook, and I'm the co-chair of the Green Operating Room Task Force. So nitrous oxide is an anesthetic gas. It's currently used to a small degree in operating rooms. It's an adjunct anesthetic gas, so it's not one of the essential gases that we use to maintain unconsciousness. It's also used in this hospital by dentistry and also to a small degree by the midwives for pain relief during labor. In our practice specifically at Sunnybrook and at the Holland, it is a mild analgesic adjunct. On its own, it doesn't provide unconsciousness, but it can be used to provide some extra analgesia intraoperatively. It's very short acting, and it sort of enhances the effect of other anesthetic gases, like, for example, sevoflurane. But I personally don't consider it in my practice an essential agent.
So we know that nitrous oxide has approximately 300 times the global warming potential of carbon dioxide. We also know that it's very persistent in the atmosphere. It lasts over 100 years, exerting that global warming potential. Nitrous oxide, although it doesn't have a large usage as compared to maybe 20 or 30 years ago, is actually very large in volume. So while there are other anesthetic gases that perhaps if you were to compare them to carbon dioxide look like they have a much higher number in terms of their global warming potential, when you look at the actual volume of nitrous oxide that we have on site and that actually gets consumed by the hospital every year, it is very significant. And the literature suggests that it contributes approximately 75% of the global warming of anesthetic gases in the healthcare system.
What she's alluding to, there's most likely a big discrepancy between what's actually consumed on the areas where the clinical use versus the amount that we're buying. I think this is the whole project to see what is that wastage, if I'm gonna call it wastage, and what is the source of the wastage.
So our eyes were largely open to this by the experience in one region of the National Health Service in Britain, and we realized that we hadn't certainly taken a look at that here, and we weren't aware that anyone else in Canada had taken a look at it. So we felt it was an opportune time to at least look into our nitrous oxide use and what impact it's potentially having.
So first we had to have an idea of what was our nitrous oxide usage. So we actually just did some queries of clinicians to see anecdotally, are you using nitrous oxide? Is it a common anesthetic gas? Is it used frequently? And then we actually looked at what our purchasing data was. So we did have to look at a lot of surrogates to sort of figure out how much nitrous oxide was being consumed by our institution. And so we were actually able to determine that over 5 years, just based on how much we filled that large bulk tank outside, how much of it we had purchased in terms of the smaller tanks, and communicating with our vendor. When they come, they fill it to full capacity. So we decided that, okay, that means on day 0, we were full. And then how much more did we have to purchase over the next few years to refill the tank, which would represent what had at least come out of the tank, whether it was used clinically or just consumed potentially through leakages, because that's what we found when we were looking at the NHS. That would give us an idea of what the total carbon footprint equivalent of the nitrous oxide used by Sunnybrook in terms of what was consumed, because we know that it's eliminated unchanged. So whatever came out of that tank would have gone into the atmosphere in some way. From that, we spoke to our vendor and they were able to give us our purchasing data. Over a 5-year period, we actually purchased over 32,000 kilograms of nitrous oxide. So that was our purchase data, and that was somehow consumed. Probably the most important person in this project is not here today, and that is actually one of the mechanics in plant operations, Daniel. So Daniel understands everything about this system, and he's been able to explain the system to us, explain how the bulk tank works, how the smaller tank works. Because when we started this project, that wasn't something that any of us really had any background or expertise in. It was just something that we were interested in, and he was able to help us understand it and also help us identify some potential actions to take so that we could actually determine if we did have significant nitrous oxide leakage. And so there's an issue of the pressure, which is actually variable and based on temperature. And because the bulk tank is outside the hospital, where the temperature actually changes frequently, and the fittings and connections on that bulk tank and the plumbing, which actually brings the nitrous oxide from the bulk tank to the hospital, because there is temperature related expansion and contraction, that's all of those joints, and there are many of them, is actually where the greatest potential is for leakage of the bulk tank. So the tank itself, which will by design vent if the temperature goes up too high, and also all of the connections of that bulk tank to the hospital.
So there is a potential solution which involves not using the bulk tank as the source or as a storage, because we suspect, and this is still a work in progress to try and confirm, but we suspect that there is leakage from the connections around the bulk tank. And there are alternatives using smaller tanks that are just used in a local sense, and you don't. And so we're actually have just started a pilot project of basically switching off the bulk tank and turning on the small tanks, and we'll be able to track if there's any loss of nitrous oxide from the bulk tank when it's actually shut off from the hospital supply.
Some areas of the hospital already use these smaller tanks, dentistry and midwifery as particular areas, and then the hospital itself has a backup system that uses a bank of 10 of these smaller tanks, and it can actually feed the entire system. So this morning at 8:30 a.m. they turned off the main tank and actually switched us over to the backup system. So we were just delighted by the speed at which that was able to happen. And then throughout this initial pilot, so those tanks were weighed prior to this happening, and the levels on the large 6,000 kilo tank outside were also measured prior to turning off the large tank and switching over to the backup system. And now we wait and we see how much are we actually using from these smaller, I think they're like a 29 kilogram tank or something along those lines, and there's like a group of 10 of them. So the whole hospital is being run on 290 kilograms instead of 6,000 kilograms. And then also, because we do have the benefit of that electronic documentation, the idea is to also see what we can pull from that electronic documentation and compare it to this time period, so that we can see if what we suspect, which is that there is significant wastage, that will help us determine what sort of the difference between our consumption and our use is.
So this project, in one sense, it's complicated because there's piping and pressures and mechanics involved, but in another sense, it's relatively easy to do, because we're not bringing about, as we see it, any impact at all on direct patient care or on the practice of the healthcare providers. This should be totally transparent to them, because we believe that the majority of nitrous oxide consumption here is actually through waste. But the message, may have been interpreted first that, hey, we're going to want you to stop using nitrous oxide because it's got a large environmental footprint. And who knows, maybe down the road there might be a message along those lines as well, but that's definitely not the initial stage here. And we had to reassure people of that, and come with us on this first step of this journey to explore, and we may be able to have a very large beneficial impact without impacting the end user at all.
In terms of the experience of the end user in the operating room, the anesthesiologist, I would be very surprised if everyone noticed the difference. At the Holland Center, where we run 5 operating rooms, we've actually been working off a bank of tanks for many years. And there's never been an issue there in terms of nitrous oxide pressure supply in the operating room.
And it does have some clinically appropriate use. So, for example, in our dental clinic, we have a lot of patients who are very vulnerable, and the dentists do use, in this very special patient population, they do use nitrous oxide as part of the ability to provide care to people who otherwise would not receive dental care in this specialized clinic. So will we eventually get to the place where we don't use any nitrous oxide at all? Probably, but what that date is in the future and what other technologies will actually completely replace nitrous oxide, that's another matter entirely. So I did look into how much we actually spend on nitrous oxide, and nitrous oxide is a fairly inexpensive gas. So I'm going to say that the reason to do this is not financial. The reason to do this is environmental. And we were actually able to look at what the impact would be and what the equivalencies of that impact would be. So we looked at how many kilograms of nitrous oxide we were consuming. We went to the EPA websites, and we were able to calculate that the amount of nitrous oxide we had used over a 5-year period, it would take planting 160,600 trees and allowing them to grow for 10 years to offset 5 years of our nitrous oxide usage, or the equivalent of driving 38 million kilometers in a car. So it's big, it's impactful, and that is the reason to do it. The financial benefit to the organization is actually going to be fairly minimal, and probably partially offset by when we decommission the tank and remove it. That actually is going to cost some money as well. And so it's probably going to end up somewhat cost neutral. So it's not going to cost a whole lot of money to actually get rid of the nitrous oxide, and certainly we haven't spent any money yet. Yet we were able to start our pilot of turning off the very large tank. So that has helped guide us in our next steps. But I would say that we are purely driven by the environmental impact.
The perspective I bring to this is a little bit from my background in cost effectiveness and health economics, and being involved in evaluation of many new clinical tools, and sometimes evaluating the removal of existing clinical tools. And so, I have a strong grounding in this sort of trade-offs involved. And we've been schooled over the years, to always consider the clinical benefit versus the financial cost. And I think we are just starting to think about clinical benefits, or possibly detriment, versus environmental costs or benefits. And so I bring very much that perspective of the trade-off. And Danette knows that, because I've sort of often jumped in and said, how do we evaluate, or how do we price that trade-off? You know, how much clinical benefit is worth an extra, you know, so many CO2 equivalents? And I think there's very little experience with that in the healthcare sector. I think we're going to gain that experience over the coming years, and it's going to be important in making these trade-offs.
Yeah. And so as Eric brings that rigor with respect to measurement and analysis, one of the things that I bring, so as the director of pharmacy, I have a good understanding of hospital systems, how things work, who to talk to, and how to get things done. And so that's probably my role in this. My perspective, so nitrous oxide is not, it's not one of the gases that's actually provided by pharmacy, but pharmacy does provide other anesthetic gases to the operating room, and a lot of other adjunct treatments to the operating room. This is actually one of those things that isn't led by pharmacy, but my background in terms of knowing who to speak to, knowing how to get things onto the hospital's quality improvement plan, and how important that is in order to bring it the appropriate visibility and move things forward and write project charters and briefing notes and things like that. That's what I bring. And then Eric makes sure that it happens with the right level of rigor and analysis and scientific support. So we complement each other very well there.
I bring the perspective essentially of the end user, and I really think it's great that I'm involved in this. So I think with any green initiative, you should make sure that the end user isn't affected in a negative way. So I think the NETS group has done due diligence to make sure that's not happening, and I bring the perspective in terms of what's the clinical importance of nitrous oxide.
I think one area that they have to keep in mind is what we've just sort of spoken about in bringing different perspectives to the project, and the end user has to be represented. Clearly on a project like this, or exactly like this, it is very, very important for us to have participation and full involvement of the folks who run the mechanical side of the operation. They understand it better, and when it comes time to actually implement some change, they're the only ones who really can do that.
There were a few things that we had to keep in mind. So probably one of the first things to keep in mind was that we needed to make sure that the messaging was appropriate, and that people heard that we were not taking away nitrous oxide, and if they needed it and they wanted it, they could still have it, but that it is a nitrous oxide waste reduction project. It's not a nitrous oxide elimination project. And I think that that messaging right from the start, and we actually incorporated that in our materials very early on because we really felt that that was important. We engaged lots of different team members, so brought in Martin from the operating room, but we also brought in people from dentistry, other areas of the building, plant operations, again, essential. We identified what our actual consumption was through our financial data, and that let us see that if we have the same level of waste as other organizations who've reported having embarked on similar projects, then that would be very impactful. And so being able to convert it into number of trees or number of kilometers probably was one of the things that helped us get the attention of our senior team. We also identified that if we were going to have this as a project, we were going to need a project sponsor. So we were going to need somebody at the vice president level who believed in this and supported it. And we were very fortunate early on that the vice president of administration, who has plant operations reporting up through him, was very supportive right from the beginning, as well as the director of our plant operations as well. And so because all of those folks were very supportive and brought on board very early on, that has allowed us to start the steps to having it put on the hospital quality improvement plan and having it get the attention and the traction it needs to take the steps forward, which included turning off the main tank this morning.
I think as a general example of an initiative, I think it illustrates a lot of things done well in terms of getting strong leadership support, also being rigorous in terms of evidence or generating evidence as you go along. Often for these environmental initiatives there's no evidence, but we can certainly accumulate data, gather data as we move along, and and then involve all the stakeholders that you think is going to rather earlier than later.